So this is a 49-year-old cop, police detective, few years of pretty bad disabling pain, even with a desk job. The guy failed conservative care, applied to his insurance company, who said they would only approve single-level surgeries, but they would be okay if I would do this 3 times for him for either disc replacement or fusion. So we made their union go back with a gun and convince them that that was the wrong thing to do. So we finally, ultimately, and here's his MRI, a stable, just 3-level degenerative disease. So we were able to get approval for a hybrid for this guy, and did 2 disc replacements above an ALIF, and he did fine for 3 months. He went back to work pretty quickly, considering he was a big, stocky guy. But he came back right before Thanksgiving, about 3 months post-op, with a lot, just an acute onset of back pain, just different back pain. So I thought he had fractured an end plate or something, but we worked him up, and his imaging showed a big retroperitoneal abscess. His white count was okay, but his SED rate and his CRP, you see, he was clearly, he had an issue. We tried to aspirate some fluid, got nothing out of it, started him on antibiotics with infectious disease, and then they started giving us a hard time about taking his implants out like it was nothing. So here's what his MRI looked like. You can see he's got, and post-op MRIs are always hard to interpret, but this was 3 months out in a guy with a SED rate of 100, and a high CRP, so you can't just ignore this. So this is what we were dealing with, and that's what the radiologist called it. So, we kind of pushed back hard against the infectious disease. They were just reading from the ID handbook that said, if you get an infected implant, you take it out, because not only is the morbidity pretty high to getting them out, but you still got to put something in his spaces to hold them. And this is not like a hip where you get unlimited shots at getting back in and out of there. So, rather than just kind of go through the line, let me just show this, because the other cases I think are more interesting. So we held off because the guy wasn't really sick. He was not an immunocompromised guy. He had no diabetes or AIDS or anything. He wasn't on steroid dependent. He wasn't toxic. And you saw his white count was normal. So we started him on antibiotics and he was doing fine. So we just decided to treat him with IV antibiotics home. But obviously keep an eye on him. And if he started to deteriorate, we would have to go back to plan B. So here he was, a year afterwards. He's no pain. He's back working as a cop. Really has no issues. He never subsided. Never got a fracture from any of his issues. So here was his pre-op MRI. There was the MRI showing the 3-month with the big soft tissue mass and the retroperitoneum. And here he is after it's all healed up. You can see his vessels. His retroperitoneum looks relatively normal again. And I just saw him back right before COVID, and he's still, he's doing fine. He's getting a little non-bridging HO, but he's still moving, and he's happy as a clam. So, the moral of the story is, fortunately, don't get a retroperitoneal infection, but surgery shouldn't always be the automatic response. That if you can treat the patient medically, here's just a very unusual case. I hope we never see another one, but the guy did well, and you got to have good partners, because of course I was out of town when the guy showed up and the infectious disease guys were pushing to take the implants out, and he said no. He said let's just let this sit. So it was just a good learning story for me, because I'd never really seen one of these before, and it's one of those things to kind of share with the guys.
I thought the answer from your on-call partner when the ID guy said take the implants out was no, but I think it was a 2-word answer.
Maybe. You may be right, but it's good that he did it. All right, so that was just for interest, because it's just something we don't see a lot of. So this is here's the last little segment of our meeting, which I think has been just wonderful. And, thank everybody for being here, whether you're participating at home or in person or on faculty. So I'm just going to show you a bunch of single slide issues of cervical arthroplasty devices, and just take a quick poll whether this is an implant issue or a surgeon issue, and what would you do now? So here's your single snapshot. Todd, is this implant or surgeon?
Is that a Mobi?
It doesn't matter. We're anonymizing all the discs. So
yeah, I'd probably go implant there. Well, both really, surgeon and implant, in the sense of if it's a hypermobile implant, they can sublux and expel.
Well,
I don't know how well the end plate was prepped posteriorly.
How about the sizing issue? Do you think there's any way that was the right size for that disc space?
It may be too big, but I don't know if originally it was back all the way.
No, I don't know. Rudy, is that implant or surgery?
That's definitely too big, and the upper end plate was never where it should be. They should be really also on the posterior borderline. That's very important, because otherwise you get this posterior bridging, and it's definitely 2 or 3 millimeters too long. So it's the wrong size, I think, what is a surgeon issue.
Armin, if this guy's asymptomatic, do you do anything?
If it's asymptomatic, I wouldn't do anything if he has no problems.
Rudy would watch it,
like
Armin? How about you?
It's like an expansive fusion.
Yeah, right.
Yeah, if it's asymptomatic, absolutely leave it alone.
Okay.
Yeah.
What if he has neck pain?
If he has neck pain, then I'd go back in, and likely in this patient, it looks like that, what is this? So probably like a C5-6. That C5 or T body is kind of eroded or subsided, whatever that may be. So likely this can end up conversion to fusion.
Todd, if he's got swallowing issues?
I'd explant. I'd attempt a revision to arthroplasty back, with a proper placed and sized disc.
Okay.
And if I couldn't do that, obviously can send him for possible fusion. Yeah.
Got it. All right, here's the next case. This was shown to me in China by a Chinese surgeon. And I hadn't seen something like this before. So what is that? What's going on back there? Todd, you want to take it?
Is that all osteophyte formation? Is that bone?
Yeah, I think it's posterior HO, or,
Wow.
I think
Wow.
I've never seen that before. That's pretty amazing. So now what? What if this guy's asymptomatic? Would anybody leave this alone?
He's not myelopathic at all?
Well, I'm just proposing. What if he was asymptomatic?
No, I would take it out, because he will get symptomatic very soon.
He's got no forgiveness around his cord anymore, and his cord looks sick.
He already shows myelopathic signs.
His cord's sick.
Yeah, myelomalacia is evident there.
Yeah, so
Explant and drill that out.
Armin, you're on board with all that, right? That's pretty straight.
No, never look at that.
Got to come out, and you think we can this 2 hemicorpectomies or 2 corpectomies, or I guess whatever you got to do to.
It looks like subtotal corpectomies.
Yeah, it looks like that Bryan disc is well incorporated into the vertebral body, and there's also some subsidence inferiorly.
Yeah, but interesting. No anterior HO, just pure posterior HO. Really kind of interesting. All right, here's another one. What do we do? Is this implant issue or surgeon issue? Todd, what's your vote?
I think it's surgeon issue. I think that I had a case similar to that, where if the lower end plate and if they're angulated such that the upper can drive the core slightly posterior chronically over time, the lower will actually slide backward gradually. And so you got to make sure these discs are really well centered and properly aligned parallel.
Jens, the surgeon that did this, told me that they were big posterior osteophytes, and he burred them down, and he said at the end of it he thinks he burred a little more than he wanted to. So is that consistent?
Yep, surgeon and tilting and too much cautelizing.
Yeah, because once that settles, the center of rotation because of the head is really anterior. So he's gone forward. Yes,
the problem on this, I may comment, because this is the center of rotation is too far posterior, and very likely the keel cut was going through the vertebra. So it is definitely a technical problem. And then if the patient is flexing his head, he's pushing the lower end plate, because here's the ball located, and the socket is pushing the end plate further posterior. So this is to be a clear technical problem.
This is like a laboratory in biomechanics once that happens. Yeah. So, no symptoms or neck pain versus myelopathy. Obviously, myelopathy would do something. But if there was just neck pain, would you revise this, Todd, fuse this, take it out, leave it in? Posterior fusion?
if it's neck pain, I'd explant and reinsert. The one I followed gradually kept moving further posteriorly over time. And so, yeah, I just explant and fuse. I doubt I'd try to re-arthroplasty that.
Armin?
Yeah, you don't have a posterior doorstop, so this is out the back, and really that's one of the probably least favorable conditions for revising to another arthroplasty. Again, in this patient, probably not, because the rest of the bone looks pretty good, but it could also potentially, in some of these patients who subside like this and go posteriorly, it could be also an indication issue in terms of poorly choosing the patient preoperatively and not paying attention to the bone density.
All right, Armin, this is coming your way, because this is an issue that I've seen in some of my patients also, where we left it in the OR in the middle, and on the first post-op visit, it's kind of drifted over. And most of them are not symptomatic, but it's just technically very disappointing for me. So what do you do to prevent that, or have you not seen that? Or
I haven't seen lateral. If we have intraop films that showed you had really good midline positioning and then kind of shifted over, I really haven't seen this much, even though in this case, you can see how on the patient's left, there was really aggressive oncovertebral joint resection. So that may be part of the problem, where then there was no lateral border to potentially, with continued motion, to kind of slowly stop the migration. So for something like this, asymptomatic, as long as it's stabilized and it's staying where it is, I'd watch it. If it's becoming more symptomatic where it continues to migrate, certainly I'd be very concerned, go back. And, this to me is a technique issue. And again, a very aggressive oncovertebral takedown is rarely necessary. And if that happens to be the case, then perhaps a fusion is a better surgery. But if this, I had to go back, once again, I'd be more leaning towards the fusion.
So this implant, you have to cut some rails to it. So this one, I think, is
LP, right?
less likely to have drifted on its own. This was probably probably put in improperly.
You have to cut the rail cuts there, and they implanted off center. And this is a common issue as well, just for the guys coming up behind on surgery. When you do an artificial disc, it's so critical you get symmetrical decompressions on both sides, and then be sure your rail cuts are dead on, because I think these rail cuts are off center.
I would agree.
Yeah, Jack, I also think it's very important what Armin said, that you should not remove the uncus completely. The posterior third is enough to do a proper decompression of the foramen. And because this is definitely a technical error, it's opening the pathway right into this side of the oncovertebrectomy. And there was also wrong positioning, because it was opening more. It was not a symmetrical release. And probably the trial was shifted into this direction, and then the kill cut was wrong. I think this was from the beginning a wrong positioning because of this excessive oncovertebrectomy.
I agree, Rudy. All right, just another case or two, and we'll get people out. So, how about this disc? Is this implant issue or a surgeon issue? Rudy, what do you think?
The way that it was left.
Yeah, this is very likely an implant issue, because it's an inferior primary fixation, but it could also be an inferior release initially, because I would love to see the intraoperative picture. Has he been all the way back? Has he done a proper release? Or if the implant was back and it's now like that, then it's an implant problem.
What implant is that?
Looks like
the LP, the Prestige LP.
To me, it looks like Rudy was saying, posteriorly, they did not decompress.
Yeah, that's what my suspicion would be also. So,
so it's like
they stopped at the 75-yard line. They nowhere close to the back.
So Todd, you'd have this would be pretty straightforward to take this out, do an appropriate release and mobilization, and then you'd feel okay putting another implant back?
Yes.
Yeah.
Okay. And then this is the last case. So what's going on here? You see the CT cuts?
Yeah.
So what's the workup for that? Jens, have you seen any of these?
Yeah, so this is an interesting phenomenon. Osteolysis around an implant is always worrisome for a nosocomial type infection, as it's now called, Cutibacter or P-bacter, Propionibacter. So SED rate, CRP, you got the CT already. I'd probably add an MRI to it to see for soft tissue swelling, or look at the soft tissue views very carefully. I'd need to know if the patient has swallowing problems, meaning dysphagia and neck pain. I might get a TC99 bone scan with respect to that. I'm worried about this being either a foreign body reaction, macrophage invasion, or a low virulence infection. I might not do anything if the patient doesn't have immediate pain, but more likely not, a revision with prior arthrodesis will be necessary.
That is a very professorial answer. Thank you.
We already did this one. He was asymptomatic. The particular patient was asymptomatic, had progressive CT erosion, and cultured positive for C. acnes.
Wow. Jack, look at that lateral X-ray, right? Just into retropharyngeal space in front of the implant. You can almost see the shadow of just some sort of inflammatory.
In there.
That's right.
Jack, yes. We have seen that quite often in M6 discs that are failing. When there is a debris coming from the polyurethane inlay, and we have seen a lot of cases where you see exactly the phenomenon. You have end plate, metallic end plate on metallic end plate. The inner part is completely gone, and you see severe osteolysis around the vertebrae above and below. So we have seen this many times here after 5-6 years when there could be the case that the disc fails completely, and then you see the osteolysis. Obviously, this is inducing macrophage invasion, and then this osteolysis, what Jens said before.
Rudy, about how many cases do you think you've seen like that?
I personally have revised about 30 cases like that.
330.
Yeah, in I personally.
Just you.
Yeah.
Okay. So this one I think is should be the last one. So it doesn't matter which disc this is, but obviously, you know, a lot of errors, but the main one being you can't leave the OR like that. And the best you could say is that maybe the surgeon had bad fluoro and wasn't aware, but, you know, just highlights that for arthroplasty. And it comes back to that question that I think Dr. Hofstetter asked me about the C6-7. If you can't see those levels, you cannot do a disc replacement. You've got to be able to see the canal and know where you're going. So, you know, we're finishing up just 15 minutes late, which isn't bad considering we had such a full program. Jens, you did a yeoman's job there. Thank you very much. And I can't tell you how thrilled I am to be associated with this faculty and this course, and Jens and the people at Seattle Science Foundation. So, Dr. Chapman, you started us off. You want to finish us up?
Yes, and in my usual practice, I'd like to, first of all, thank you, Jack. You ran with us, you, Rudy. There's such a group of people, Armin, Todd, you've been pioneers in this field, and I feel lucky to get to ride on your coattails. May I defer my closing comments to the person who brought the disc to these shores, Dr. Scott Blumenthal, 20 years later. Give us a big picture perspective to pick up on the opening theme. Where were we when this started, and where are we now? What have we learned?
You know, I don't know, because I didn't sit through all of Jack's talk. If he has the slide of the last 20 years where the literature went from 0 to 2,000 papers on this technology of cervical and lumbar arthroplasty. I would agree with, I think, what you said earlier, Jens, that cervical arthroplasty is the standard of care, the gold standard now for herniated cervical discs at 1 or 2 levels. And I'd echo what Jack said, is how much more data do we need in lumbar to get the naysayers, both the payers and the surgeons, to realize that in properly selected patients, we've raised the bar on outcomes for a very tough problem, lumbar disc degeneration. So I think we just keep doing this and keep, you know, presenting objective, you know, data, and we'll get there. In closing, I personally would like to thank our SSF
team who is just fantastic, and industry without whose support this would not be possible. And I hope everybody really enjoyed it. Our audience, you've been great. We have still about 68 people there. We were over 100 for a while from around the world. So thank you all. This was a lot of fun for us. To be continued next year.
Amen. Thanks, Jens. Have a good weekend, everybody. Safe travels.
Thank you.
Thank you, Rudy.
Have a great weekend. Have a great weekend. I go sleeping now.
All right. Good night. Good night.
Good night.